Bismillahirrahmanirrahim. Gupta CVS. Chest X question number 1. Chest X equals bilateral hilar axial calcification diagnosed as asbestosis. Bilateral hilar axial calcification seen as asbestosis. Question number 2. In an anaphylactic axis, dose of intramuscular adrenaline is 0.5 milliliter of 1 into 1000 adrenaline. In an anaphylactic axis, dose of intramuscular adrenaline is 0.5 milliliter of 1 into 1000 adrenaline. Question number 3. On chest X-ray, fibrotic change predominant in upper lobe, diagnosed scleroderma. On chest X-ray, fibrotic change prominently dominant in upper lobe, diagnosed scleroderma. Another thing is, on chest X-ray, fibrotic change predominant in upper lobe is seen in scleroderma. Now, usually, okay. In asbestosis, there is bilateral higher axial calcification. The asbestosis, this is a progressive massive fibrosis. So bilateral axial calcification is seen as asbestosis. Higher axial calcification. Question number 4. African man with bilateral lymphadenopathy and elevated ACE most likely diagnosed is sarcoidosis. In this, the hint is bilateral lymphadenopathy, high lymphadenopathy, and elevated ACE. So diagnosed is sarcoidosis. Question number 6. Perfusion images shows multiple segmental filling defect, and the ventilated image shows normal ventilated in equilibrium and water images most likely diagnosed is pulmonary embolism. The perfusion images show multiple segmental filling defect, and the ventilated images show normal ventilated in the equilibrium and water image most likely diagnosed is pulmonary embolism. Question number 6. Female non-smoker chest X with marked lucency in both lower zone. Female non-smoker female with marked lucency in both lower zone with severely displaced right horizontal figure, superior displaced right horizontal figure, and flattening hemidiaphragm, diagnosed alpha-1 antidiaphragm deficiency. Female non-smoker shows marked lucency in the both lower zone with severely displaced right horizontal figure and flattened hemidiaphragm, diagnosis alpha-1 antidiaphragm deficiency. Because right lung is swollen or just there's bilateral lucency in lower zone. Question number 7. Man has gradually progressed dyspnea for 2 years. Chest radiograph shows reduced lung volumes and with auricular size of changes in both lung zones. HRCT shows peripheral and basal auricular opacity, honeycombing, and traction bronchiectasis. Diagnosis idiopathic pulmonary fibrosis. The man has gradually progressed dyspnea for 2 years. Chest radiograph shows reduced lung volumes. One hint is this: reduced lung volumes, and HRCT shows honeycombing and traction bronchiectasis. So diagnosis idiopathic pulmonary fibrosis. Question number 8. Man chest aerograph shows a right paratracheal soft shadow. Here shows the right paratracheal mass in the mediastinum which contains fluid of 10 Hounsfield unit. This has a well-defined margin. Diagnosis is bronchogenic cyst. So simple. Chest aerograph shows right paratracheal soft mass with the tracheal soft mass. Then CT scan shows masses in the mediastinum which contain 10 Hounsfield unit. Well-defined margin. Diagnosis bronchogenic cyst because it is paratracheal. Paratracheal mass is most likely bronchogenic cyst. Question number 9. Female non-smoker, the chest radiograph shows basal airface shattering. Chest CT shows air bronchograms with a background of ground glass opacity. There is septal thickening and bilateral fluid appearance. Diagnosis is acute interstitial pneumonia. Now, acute interstitial pneumonia because there is airface shattering, air bronchograms, and background ground glass opacities. So acute interstitial pneumonia. These signs and symptoms do not fit any other disease. So airface shattering plus air bronchograms plus background ground glass opacity, acute interstitial pneumonia. Female non-smoker chest radiograph shows bilateral airface shattering, air bronchograms with bilateral ground glass opacity. Question number 10. Minor has shortness of breath for 7 months, calcified fluid plaques at both lung bases, honeycombing, diagnosed as asbestosis. The calcified fluid plaques at both lung bases, honeycombing, and the plaques at the bases is seen as asbestosis. Calcified fluid plaques at the bases is seen as asbestosis. Another hint is minor. Question number 11. Sex X-ray shows 5 cm subpleural mass in right lower lobe. There is line opacity from the lower pole of the mass and mass courses toward hilum. The CT confirms it, diagnosis round electasis for fixed sign. This is round electasis. These are the round electasis. Sex X-ray shows 5 cm subpleural mass in right lower lobe. Remember that this round atelectasis is in the pleura. It's a slab pleural mass. And then on CT scan, there's curvilinear opacity uh, arising from the lower part of the mass and coursing towards the hilum. Diagnosis round atelectasis is called Crowfeet sign. Number 12, chest X-ray shows hydropneumothorax, heart HRCT shows thin wall cyst throughout the lung, diagnosis, and pneumomatosis. Chest X-ray hydropneumothorax, HRCT shows thin wall cyst throughout the lung, diagnosis, and pneumomatosis. Question number 13, chest X-ray shows 3 cm subperitoneal nodule with an apparent draining vessel from the hilum, diagnosis, pulmonary arteriovenous malformation. Chest X-ray shows 3 cm subperitoneous nodule with an apparent draining vessel from the hilum, diagnosis, pulmonary arteriovenous malformation. Question number 14, pet shop owner has shortness of breath, his HRCT shows diffuse ground glass centrilobular opacity in both lungs, diagnosed as hypersensitive pneumonitis. Pet shop owner is the hint, and then he has diffuse ground glass centrilobular opacity in both lungs, diagnosed as hypersensitive pneumonitis. Question number 15. Woman unresponsive on street, pinpoint pupils is seen in opiate overdose. Woman unresponsive on street, pinpoint pupils, chest angles with bilateral diffuse patchy air space sharing in mid and upper zones with central peribronchial stuffing, diagnosis, pulmonary edema secondary to opiate overdose. Woman unresponsive on street, pinpoint pupils and chest angles with bilateral diffuse patchy air space sharing in middle and upper zones with central peribronchial cupping, diagnosis, pulmonary edema secondary to opiate overdose. Question number 16. A woman had pleuritic chest pain, history of intravenous drug abuse, chest X-rays with bilateral lung cavities, both thin and thick walled, diagnosed septic pulmonary emboli. The patient has pleuritic chest pain, history of intravenous drug abuse, so he has may have infective endocarditis. Chest X-rays with bilateral lung cavities, both thick and thin walled, diagnosed septic pulmonary emboli. Question number 17. A homosexual positive HIV, such X-rays with bilateral upper lobe cavities and pancreatic opacities, small right pneumothorax, diagnosed with pneumocystis jirovecii pneumonia. Now, homosexual positive HIV patients, and then chest X-rays with bilateral upper lobe cavities and higher pancreatic opacities, small right pneumothorax, diagnosis, pneumocystis jirovecii pneumonia is caused in HIV patients. Question 18. A foundry worker has progressive shortness of breath. Chest X-rays with bilateral upper lobe opacities with higher lymph node shows extra calcification, diagnosis, silicosis. Now, patient is foundry worker, so in foundry worker is exposed to silica. Foundry worker and chest X-rays with bilateral upper lobe opacities with higher lymph nodes showing extra calcification, diagnosis, silicosis. In asbestosis, there are plaques involving the lower part of the lung, lower pleura walls. Question number 19. Chest X-ray shows 2 cm round mass in the left lower lobe. CT shows an enlarged feeding artery and a draining vein, diagnosed arteriovenous malformation. The AVM, okay. Chest X-ray shows a 2 cm round mass in the lower lung zone, and CT scan shows an enlarged feeding artery and draining vein, diagnosis arteriovenous malformation. Chest X-ray shows a 2 cm rounded mass in the left lower lobe, and CT scan shows feeding artery and draining vein, diagnosis arteriovenous malformation. Question number 20. Man getting treated for lymphoma has chest pain. Chest X-rays with blood test normal. VQ scan shows patchy areas of ventilation defects, unlikely diagnosis. Pulmonary embolism is unlikely diagnosis because on VQ scan there's patchy areas of ventilation defects. A man getting treated for lymphoma has chest pain. Chest X-rays with blood test is normal. VQ scan shows patchy areas of ventilation defects, unlikely diagnosis. Pulmonary embolism unlikely diagnosis because there are patchy areas of ventilation defects. Patchy areas ventilation defects, so unlikely diagnosis pulmonary embolism. आवाज आ रही है ना?
Yes, sir.
इससे पहले थोड़ा सा आहिस्ता था. अच्छा ठीक है. Question number 21. HIV positive man has cough, chest X-rays of bilateral intestinal infiltrate and apical ground glass serving causative organism, pneumocystis jirovecii. HIV positive male has bilateral intestinal infiltrates and apical ground glass serving causative organism is pneumocystis jirovecii. Question number 22. A woman has left proptosis and pain, chest X-ray has mass in lung apex, superior sulcus tumor eroding through the rib, diagnosed squamous cell carcinoma. Another option is because superior sulcus tumor is on left side, not pancreas. Okay. Woman has left side proptosis This actually has mass in the lung apex and superior circle tumor. Superior circle tumor is caused by squamous cell carcinoma. Superior circle tumor is caused by squamous cell carcinoma. And pancreas tumor is caused by small cell carcinoma. So when they tell you that there is superior circle tumor, then it's caused by squamous cell carcinoma. And if they say pancreas tumor, then it will be small cell carcinoma. Question number 23. A smoker with chest pain and cough. The scan shows 3 cm specular mass in the right upper lobe, abutting the lateral chest wall. Histology is adenocarcinoma because peripheral lung tumors is adenocarcinoma. Smoke with chest pain and cough. CT scan shows 3 cm specular mass in the right upper lobe, abutting the lateral chest wall, which is peripheral. Abutting the lateral chest wall is peripheral. Histology is adenocarcinoma because it is peripheral. Question number 24. Chest aggregate shows left paraspinal soft tissue density behind the heart. CCD shows its 6 cm lobulated mass, 6 cm lobulated mass. There is feeding artery from the thoracic aorta to it, diagnosed interlobar sequestration. The chest aggregate shows left paraspinal soft tissue density behind the heart. On CCD, there is 6 cm lobulated mass. There is feeding artery from the thoracic aorta to it, diagnosis interlobar sequestration. These are all interlobar sequestration. Question number 25. On CT scan, intimal flap in ascending aorta with contrast filling on either side. Arch and descending aorta normal. Diagnosed DBK type 2 dissection of aorta. Now on CT scan, there is aortic dissection. Okay. These are also aortic dissection. This is type 1. Because both are involved, ascending and descending aorta. But here they are saying that intimal flap is seen in ascending aorta and arch and descending aorta are normal. So diagnosed DBK type 2 descending aorta. That's question number 26. None present cup just radiograph opacity in the right cardiopenic recess. Opacity in right cardiopenic recess. CT scan shows 4 cm lesion apparent in the pericardium. Lesion contents a hospital urine of less than 10. Diagnosed pericarditis. None present cup just radiograph opacity in the right cardiopenic recess. CT shows 4 cm lesion apparent in the pericardium. Lesion contents have hospital urine of less than 10. Diagnosed pericarditis. Question 27. Thin curving line area of calcification in the lower part of the left heart border. Very like the side of the calcification left ventricle. Thin curving line calcification in the lower part of the left heart border. Like the side of calcification left ventricle. This is diagnosis of left ventricular aneurysm. So thin curving line calcification in the lower part of left heart border. Very likely the side of calcification left ventricle. Not left heart border. So left ventricle. Question number 28. A chest aggregate shows enlarged heart with laterally displayed left cardiac apex and a metallic ring shadow seen to be overlapping the spine and horizontally positioned. Which cardiac valve is this? Aortic valve. Now they are saying here, aortic valve over here. Chest aggregate shows enlarged heart with laterally displayed left cardiac apex and a metallic ring shadow seen overlapping the spine and horizontally positioned. So here the mitral valve, but horizontally positioned and overlapping the spine. Which cardiac valve is this? Aortic valve. This is diagnosed of mitral stenosis. Question number 29. Cardiac pacemaker of the electrode lies 3 cm to the cardiac apex. Where is the most likely site? Right ventricle. The cardiac pacemaker. The tip of the electrode is 3 cm to the cardiac apex. Where is the most likely site? Right ventricle. Tip of the electrode is 3 cm to the cardiac apex. Where is the most likely site? Right ventricle. The cardiac apex 3 cm to it is going to be in the right ventricle.